everyone, I'm Cecilia Gigena from Cincinnati Children's Hospital. We are summarizing the talks of the update course in Pediatric Surgery 2022. This talk is about Management of Esophageal Leaks. The moderator for this talk was Dr. Harmon, and as speakers we have Drs. Miguel Guelfand, Jorge Godoy, and Michele Ugazzi. So, they started by presenting a case.
A 10-month-old female with a long gap esophageal atresia, status post laparoscopic gastrostomy tube at birth, measurement of the esophageal ends just before surgery, an end-to-end esophageal anastomosis was done, slight tension. 5th day post-op, there was a right pneumothorax. Esophageal contrast shows a large esophageal leak into the pleura, regular passage of distal esophagus and stomach. Now, before I go further, for those in the room, I'm going to ask, if you just had a small contained leak after your esophageal repair, not coming out the chest tube, just contained, who would just watch that?
They say that every small or moderate leak that it's contained, it can be managed by observation, and there's no need for a new intervention. So that leads us only consider a new intervention and leaks that create huge pneumothorax are not well drained, or even if the patient is unstable. Okay, so let's see what Dr. Michele Ugazzi did with this patient.
So this thing was managed with chest drain, mild suction, negligible plug tube, and you add botulinum toxin.
Yeah.
Why?
Because the saliva.
So there was too much saliva for an ENDOVAC to work. So what he did is he put an NG tube and blocked the creation of saliva. That can be used with Botox, as he did, or glycopyrrolate. That is a new medicine that it's available here in the US that blocks the secretion of saliva.
So the leak stopped, I guess.
Yeah.
And you have an endoscopy after.
Yes.
Why?
Because we want to see how was the esophagus. So we did endoscopy. You cannot look very well for upper side because there's a lot of
there was a
sutures. So it's better to go back and put the wire through the
gastrostomy.
So
you will have retrograde endoscopy.
Yeah, and then you do that. And it was great.
Okay, so let's rephrase. With the treatment, the leak stopped and the esophagus was healed, but it healed with a stricture. So to manage that, they went on to do an endoscopy, but a normal endoscopy was not enough because they can't see anything because of the stricture. So what they did is, as these patients got a G-tube first, they put a wire through the G-tube to the esophagus and then dilated from there. That is called a retrograde endoscopy, and it worked really well. So now we are ready for the next case.
So here we've got a 2-year-old whose status post-esophageal atresia repair at another hospital, type 3C, high underdiagnosed proximal TEF. So we fixed the type C, but surprise, there's a proximal fistula. Surgeon decides to resect through the neck. 6 days after surgery, that's a problem. A leak, big leak coming out the neck.
So it's coming out of the neck through the cervical incision. What do you do?
Oof, really tough case. It seems that everyone agreed that we can start treating these patients with a drain in his neck. But let's see if Dr. Miguel Guelfand has something else to do with this.
This is the endoscopy. We did an endoscopy. Get the patient to the OR, get an endoscopy. So again, that's a fistula, and you can see air coming out through the, okay? So we decide to put an ENDOVAC.
ENDOVAC. This is an endoscopic vacuum closure. But how can we do this? Fortunately for us, we have Dr. Miguel Guelfand that will help us know when and how to use this.
This is a paper described by Cristobal Abello. He's a very, very, very intelligent guy as Jorge as well, to how to do an ENDOVAC. So it's online. It's very easy to make it. Actually, that's how it looks. It's like an NG tube attached with a sponge, and you can use a duoderm or a tegaderm or something to protect that thing. But you just put it down through endoscopy and by radioscopy, just to sit it in the side of the fistula, and you can get suction You can see it on the esophagram that the leaks completely shut down immediately. And that you keep that for 4 or 5 days, and then you review that, again in the OR. And this is the view 5 days after, completely closed.
Okay, so let's repeat. This is an empty tube with a hose covered by a surgical sponge, and that is covered by a perforated transparent adhesive. So we put that into the patient and connect it to suction. So this is supposed to help the granulation tissue form by negative pressure, and this will make the patient heal faster. And if you want to see more, you have a link in the description that takes you to a video where you can find how to do and when to use an ENDOVAC. And now it's time for the last case.
It's a patient had done a esophageal atresia, type C, with no problems. Newborn, 7 days, 40 weeks, 3,300 grams.
They performed a thoracoscopic repair, and at day 3, they found a leak.
And you can see the leak there. So Jorge said, I'm happy you said
Yes,
shouldn't be there,
exactly.
to take it to the OR again.
Interesting case, but why a surgery this time?
Because in these cases, really I am happy for the suture without tension. I don't understand because the leak.
Well, what Dr. Jorge Godoy explained us is that this was a pretty common surgery, no problems, no tension in the anastomosis, and the leak was very big and not explained by anything. And though not everyone agreed with this approach, he thought the surgery would be the most effective way to treat this patient. But let's see the results.
First study
3 days after,
look,
and went well.
no stenosis. And repeat the study 3 weeks ago. I looked at no stenosis. At this patient, no require dilatation.
So
Awesome. No more leaks and no strictures. What a great session. So now it's time to summarize. First, most of the esophageal leaks can be treated by observation or chest drain. Second, if there's an external leak like in the neck or a fistula that's not healing well, an ENDOVAC can be a great solution. Third, for some patients with deteriorated status or great leaks, a reanastomosis can be attempted. Fourth, after a leak, a stricture is more common, so you have to follow the patient more thoroughly. I'm Cecilia Gigena from Cincinnati Children's Hospital, and that was everything for today. And remember, we are sharing knowledge to improve child health around the globe.